Uh, Very good evening, ladies and gentlemen. It's my proud privilege and honor to introduce Dr. Sandeep Diwan, speaker for today on cadavers, contrast and regional anesthesia. He works at Sancheti Hospital, Pune, and he has an illustrious CV which runs into pages. And today, I'm sure all of us will benefit from his lecture. Over to Dr. Diwan for his lecture on cadavers, contrast and regional anesthesia.
Thank you, Divesh. Can you hear me? And can you
Yes,
see my
sir.
slides?
Yes, sir. We can see your slides and you're audible, sir. Please go ahead.
Thank you so much. Hi, everybody. Hi, Ritesh. Welcome back. We'll be looking into cadavers, and I've just put in some slides regarding the contrast just to illustrate how the spread of the dye occurs in the live apart from the cadavers. So we are looking into only five sites: superficial cervical plexus, the phrenic nerve, the thoracic paraspinal space, the pen, and the calcaneum. So, coming to the superficial cervical plexus, we are not going into the details of how it is formed, but this is one of the uh, dissections that we made, and you can see that this is the sternocleidomastoid on the left side, and this is the midpoint of the sternocleidomastoid from which emerge the upper cervical plexus and the lower cervical plexus. Now, we are more interested into the lower cervical plexus as we do a lot of orthopedic surgeries, and it's all related to that. So this is the lateral, that is the intermediate, this is the medial supraclavicular nerves, and these would be the greater auricular and the transverse nerves. Now, more importantly, this you can see the pad of fat from which it exits, and there is definitely a different site of emergence of these nerves, the upper cervical plexus and the lower cervical plexus. So we find that there's a difference of maybe around 1 to 2 millimeters all the time. This is in a pad of fat, and this rests on the middle scalene muscle. And immediately below this, you will find the prevertebral fascia, which encloses the brachial plexus and the phrenic nerve. So probably large volumes of local anesthetics, which were injected in the past with non-ultrasound techniques, they would cause phrenic nerve paralysis and brachial plexus analgesia or anesthetic as well. Now, when we trace these nerves, you will find that it usually exits through some sort of the tunnel here. And this tunnel is usually a facial opening, which leads to the deep cervical plexus. So, large volume of local anesthetic, which is injected in this area, is likely to migrate through this tunnel and lead to the deep cervical plexus blocks. And this has been demonstrated by uh, it's probably Pandit in British Journal Anesthesia somewhere in 2000. Now, why would be this would be important is basically because you'll see that the lateral supraclavicular nerve, it goes until the mid of the arm. And this is necessary to be blocked during the proximal humerus and the mid-shaft humerus surgeries. And the mid supraclavicular nerve, it goes until the level of T4. And this is the reason why needs to be blocked during maybe the
You have to
mastectomies.
bring our toothbrush.
Hello?
Please continue, sir. Please continue.
So now when you inject contrast in the superficial cervical plexus, you'll find that in the sagittal plane between the sternocleidomastoid and the trapezius, this is the spread of the dye. That's around 10 ml of local anesthetic. In the axial section, it spreads in the erectospinal plane, but lateral to that until the trapezius. And in the coronal plane, you will find it spreading right into the level of the brachial plexus. So 10 ml of local anesthetic in the superficial cervical plexus can spread in all these areas. In again in the coronal sections from the level of spinal cord until the spinous process, you will find that it spreads between the levator scapulae and the trapezius. It would probably block the dorsal scapular as well as the levator as well as the spinal accessory nerves. So this is at the level of the brachial plexus, you can find the superior trunk here. This is the superior trunk, and then this is the brachial plexus, which then moves on into the axilla. So it can trickle on to the superior trunk as well. So that's how the facial planes lead to. Now, this was a young adult. So in the elderly, where the facial planes are very fragile, you can see lots of local anesthetic moving across the facial planes. Now, this we have published. 2 ml at the level of C4 in the investing layer of deep cervical fascia can stain the C4 and C5 and the phrenic nerve, but it will not stain the C3. You can look here, it doesn't stain the C3, but it stains the C4, the supraclavicular nerve, and they have a definite topography. The C4 supraclavicular nerve and the phrenic nerve have a definitive topography which you can easily visualize on ultrasound. And it's very important to understand that at the level of C4, the volume of local anesthetic has to be very less to avoid a phrenic nerve paralysis. Now, coming to the level of clavicle, we have published at least two blocks, the C5 and supraclavicular, superficial cervical plexus, and the scud block. Now, the other block which it has emerged is the clavipectoral fascia block. And if you look into the innervation of the clavicle, you will see that the whole of this is all innervated by the supraclavicular nerve. Now, in fact, there are some articles which mention that there are tunnels and uh, holes which lead to the supraclavicular nerve, which actually pass through these tunnels in the clavicle, and they are the ones that innervate the clavicle. So they have got a definitive role in the innervation of the clavicle. The subclavian nerve, we see that the subclavius muscle, which is attached in the posterior area, is innervated by the subclavian nerve, while the lateral pectoral nerve, it would also it would also innervate the clavicle through the pectoralis major. So it is still under process, the innervation of clavicle, and in fact, we are also studying about the innervation of clavicle through a separate kind of anatomic investigation that we are looking into. Recently, an anatomical study by one of my friends, Xavier, and he mentioned that when you inject dye in the clavipectoral fascia, it would stain the superficial cervical plexus and the deep muscle plane, but that would be on the anterior and the superior aspect, but nothing on the posterior aspect. So that is what it lacks. There is no stain of the posterior aspect along the pectoralis major attachment and the subclavius muscle attachment. So this is the article which mentions both on the right side and the left side, the front and the rear view. And you can see the rear view, it is not stained at all, while at the front on the left and right, it is consistently stained. So they came to a conclusion that the posterior inferior region of the clavicular periosteum or the deep muscular plane, including the clavipectoral fascia, is not affected at all. So we are yet unsure whether the clavipectoral facial plane block would really give you a good anesthetic or analgesic in the perioperative period. Coming to the phrenic nerve. Now I would this slide I would like to introduce you to some of the systematic reviews which have been published about phrenic nerve paralysis. Now, when you look at the slide, this is the phrenic nerve. It is around 1.8 to 2.2 millimeters from the level of the brachial plexus. But it has been clearly mentioned by Kessler that in his article that the C5 is indistinguishable from phrenic nerve at this point. And it's possible. You can see that this would be absolutely impossible to distinguish. As you go more low down, you'll find that the nerve separates from the brachial plexus 3 millimeters for every 1 centimeter. This is the point where you would be giving the interscalene block. And more than 20 ml, there is grade 1 evidence that it can lead to 100% diaphragmatic paralysis. If you perform it by ultrasound, 10 ml will give you 33%, 20 ml will give you 66% of diaphragmatic paralysis, and less than 4 ml, it's questionable whether it leads to a 0% hemidiaphragmatic paralysis. So you need to go down at the level of the superior trunk, where you inject around 15 ml with the incidence of 24%. And if you reduce it to 5 ml, the incidence is down to 4%. If you go still low down at the level of the supraclavicular nerve, suprascapular nerve, this is the suprascapular nerve, that would be the posterior and anterior divisions, you will find that it is still around 4% of hemidiaphragmatic paralysis. Now we are unsure about why just 5 ml should cause a diaphragmatic paralysis. Since the distance would be more, definitely it would not travel more horizontal. It has to travel cephalad. But does 5 ml travel cephalad? So this is again a area for research. Now, if you insert catheters, which we routinely do for some of the orthopedic surgeries like these proximal humerus, we can see very well the delineation of C5, the C6, the C7, C8, and you will find that the T1 is not involved here, but there is some tie on the at the level of the first tree, and it could probably stain. The continuous blocks can probably soak the inferior trunk. Now, if you look here, this is the axial section, while this is the coronal section. What you'll find here is, so this is the green one is the phrenic nerve, which would be probably involved in continuous blocks and lead to a continuous diaphragmatic paralysis. This light arrow is the path of the suprascapular nerve. That would be the path of the lateral pectoral nerve, and that would be the path of the axillary nerve. Now we know that the shoulder is innervated by all these three nerves and also the lower subscapular, which arises from the posterior cord. We have not yet gone into that particular nerve. So a continuous interscalene block would be the block of choice for a complete postoperative analgesia for the proximal humerus surgeries or even for total shoulder arthroplasties. Now, when you see in the axial section that the one which is encircled by green is all the contrast. That is the foramen transversum through which the vertebral artery would arise. And this would be the path of the brachial plexus. So the contrast surrounds all the three cervical rami or the trunks at this level. So this would be a complete block, but at the cost of the phrenic nerve, which would be very close on the anterior scalene, and which would be engulfed by the local anesthetic. So probable blockade with the continuous block. So we wanted to study the pathway from the suprascapular nerve until the phrenic nerve. What we did by ultrasound, we gave an injection of 5 ml of methylene blue dye very distally at the suprascapular nerve. And then we gently dissected the whole thing. This is the clavicle, which has been totally retracted to expose the brachial plexus. What we found was that there was a path from the suprascapular to the superior trunk, and then posterior to the brachial plexus, it would wind around and then come onto the phrenic nerve. And this is possible because if you go into the details of the suprascapular nerve topography, it has been given in literature how it is very close to the phrenic nerve, and it might share the same facial sleeve. And this is a possibility, and this is what we have written in this particular article. And it also stains the superior trunk as well. So the mechanism of suprascapular nerve is probably by staining the superior trunk and giving you the analgesic quality. At the same time, the phrenic nerve blockade is possible with a very small volume, which is injected more distal. So diaphragmatic paralysis will exist even if you inject most caudal site. The incidence would be very, very less, as mentioned, around 4%. And we're trying to find out in a couple of cadavers, which we are doing at several centers, how much of what would be the incidence, the anatomic blockade of phrenic nerve after injecting more distal at the suprascapular site. So are there any alternatives? Now the alternative for is would be an infraclavicular block, which has been mentioned. Now we have seen that this is the superior trunk, and this would be the block of choice, and which gives rise to the pectoral nerves, the suprascapular nerve, the axillary nerve, and the musculocutaneous nerve. A very nice specimen which I found in Coimbatore when we did the cadaveric workshop. This has been dissected and painted by Dr. Amruta. She's the head of department. Now, so we are trying to see whether if you inject at this point, that is the at the level of the posterior cord, whether it would suffice the blockade. Naturally, the pectoral nerve, the axillary nerve, the musculocutaneous nerve, and the subscapular nerve, which is not seen here, can be blocked with the infraclavicular, but not the suprascapular, which would be arising from this point. So when I went back and did some, I just tried to scan some of my old slides. I found a very good slide which I had injected in the past at the posterior cord, that is here, and contrast, and around 20 ml, around 30 ml, along with the local anesthetic. And what I found was very interesting. I found the contrast which was spreading from the posterior cord, retroclavicular, onto the supraclavicular, and then into the superior trunk and interscalene area. So when I found this slide, I had injected in this particular area. This was in the infraclavicular area. It, of course, went more distal in the axillary. But what was interesting was that this had migrated or translocated through the costoclavicular area, which is now we mentioned, the retroclavicular area. This is the supraclavicular divisions. You can see the hypoechoic fascicles there. And then there was extension into the interscalene and going to one of the roots. Single point injection had blocked all the three, the lateral cord, posterior cord, and as well as the medial cord. So this is a possibility that infraclavicular blocks can give you a shoulder analgesia. Of course, we have seen that now costoclavicular, they do provide the supraclavicular blockade as well, suprascapular blockade. Now, what remained was the subscapular nerve. So when we had a cadaveric workshop in in Kolkata, which was arranged by Arunangshu, so the anatomist there, he called me and he said that, do you want to see the subscapular nerve? Because I was trying to mention that it was not possible to be seen. So he demonstrated how the subscapularis nerve, it lies in the subscapularis plane along with the axillary nerve, the thoracodorsal nerve on the subscapularis muscle. So it lies in that way. The axillary nerve, which is at the apex and more lateral, then comes the thoracodorsal, and then comes the subscapularis nerves, the upper and the lower subscapularis nerve. And this has got a minor contribution to the shoulder joint. This is the reason why now we perform the anterior approach to the axillary and the subscapularis nerve. So this is the needle which would enter into the subscapularis plane, and these hypoechoic, whatever you see, are the neurovascular structures. This is the subscapularis muscle, and when you inject local, you'll find that it it gets floated into the hypoechoic local anesthetic, which is injected both the axillary and the subscapularis nerve. So now we are combining uh, just around 4 ml of infraomohyoid isolated suprascapular nerve and the injection into the subscapularis plane, which is around 10 ml. But that 10 is not very deep because you'll find that it's quite superficially placed, these nerves. So you don't have to go very deep and inject local because the subscapular muscle, it starts from this point, and it's a wide muscle, it's a thick muscle, and it has got a beautiful plane which you can always see during your ultrasound guidance. Coming to the erectospinate plane block, which I have worked a lot on this cadavers. Now this is a specimen that we cross-section in Graz in Austria along with George Fiegel. And what you see is the paravertebral space. This entire is the paravertebral space. Now this has got the motor, sensory, and the sympathetic trunk. This is the anterolateral border, that's the pleura, that's the medial intervertebral foramen, and posteriorly will be the costotransverse junction. So the spinous process, the transverse process, the costotransverse junction, and these are the ribs. So you have the paravertebral space here. Then you have the another space, which is the costotransverse space, which would be better seen in sagittal sections, which we are going to see. And then we have the deep erector spinal plane. I call it as a deep erector spinal plane because this is the terminology I have used in my article. So I mentioned as the deep erector spinal plane. So the blue line is the deep erector spinal plane. The purple is the costotransverse space, and the paravertebral space is this particular space. So what you do is when you inject into the paravertebral space, there is a chance going into the epidural space and the intercostal. When you inject in the costotransverse space, there is a slim chance of this going into the epidural space and the intercostal space. And when you inject into the deep erector spinal plane, there would be even lesser chance of that going into both these spaces. So it depends upon what type of cadaveric study you do. You are using a formalin based, or you're using a fresh frozen, or you are using a thiel embalmed or soft embalmed cadavers. It all depends on that. And second would be the choice of latex. What latex? What choice of dye you're using? Is it a latex which is viscous, or you're using a non-viscous like a methylene blue dye? So when we did this particular study, we were quite impressed when you inject in a formalin-based cadaver at the level of T5. Now remember, the anatomic literature always mentions that at the level of T5 and T4, the costotransverse ligaments are deficient. It's very important to remember this. And there's a possibility of spread of large volume of local anesthetic into the ventral space. So when we injected into the erectospinal plane or a paravertebral space on the other side, we never knew that this we could get this kind of picture. So when we injected in the erectospinal plane, it went anteriorly into the ventral paravertebral space and into the epidural space. And when we injected into the paravertebral space, again went into the epidural space, in the intercostal space, and then into the erectospinal plane. So probably since we did not knew that we would get this kind of picture, otherwise the next plan was to inject a blue dye here and a red dye here, or probably inject blue dye in all cadaveric specimens on one side and a separate injections in other cadavers on in the other side in the paravertebral space. So we did some a study on the patients with chronic pain who had come with pulmonary mets and severe thoracic pain. So we injected through catheters into the ESP plane, and we found that the contrast it goes to the costotransverse foramen. In fact, there are three points of entry from the ESP plane into the paravertebral space, and we have mentioned this in this literature. The contrast actually comes to the costotransverse foramen into the paravertebral space, in the intervertebral foramen, into the posteroepidural space, and the contralateral epidural space. And many times when we do this for spine surgeries during the dorsal thoracotomy, the dorsal spine surgeries, when we inject at one particular level, we find that there is a drop in the pressures. And when you inject on the other side, there could be a severe drop in the pressures as well. So you need to be very careful when you do these blocks on either sides in patients at the level of T5 for dorsal spine surgeries. So this made us to go ahead and study the anatomic barriers to these paraspinal blocks. So this we did with Xavier in Barcelona. And what we found was very interesting. This is a sagittal section. So you need to focus on certain things. We are coming from dorsal to ventral. This is the erectospinal plane. We call it as the deep erectospinal plane, just below the erectospinal muscle. These are the transverse processes. And between the two transverse processes will be the intertransverse ligament. These ones. Now, between the transverse process and the rib will be the costotransverse ligament. So this would be the costotransverse ligament. And between the intertransverse ligament and the costotransverse ligament, I call it as the interligamentary space. And beyond the costotransverse ligament would be the paravertebral space. So now if you're injecting a local anesthetic at this point, there will be the intertransverse ligament, the costotransverse ligament, and the intertransverse ligament, the interligamentary space, and the costotransverse ligament. Only then the local would be migrating towards the paravertebral space. But if you inject in the interligamentary space, there would be just one particular anatomic barrier. The motor sensory or the ventral and the dorsal rami would be in the paravertebral space. The dorsal rami would be in the interligamentary space, and the branches of the dorsal rami would be in the erectospinal plane. So ideally, if you want a motor sensory and a sympathetic blockade, we would inject in the paravertebral space. If you want just the dorsal rami, we would inject in the interligamentary space. So if you get your needle at this point, that is at this point, that would be the erectospinal plane block. If you insert a needle through the intertransverse ligament, this would be the costotransverse space or the interligamentary space. You would get hold of the dorsal rami. And if you insert your needle beyond the costotransverse ligament, your needle would be in the paravertebral space, and you will can capture the ventral nerve. So this particular article, a systematic review, it mentions that in the erectospinal plane, when you inject, there will be 100% spread in the erectospinal plane, 57% in the paravertebral space, and in 38% in the epidural space. And they also mentioned that further research is required to understand the relationship between injected volume, timing of assessment, and injected spread. So every time you read an article, you end up with questions. So we try to understand that whether these anatomic barriers are really the barriers for the injection. So we performed injections at these three levels. So one was at the erectospinae, the second was in the costotransverse or interligamentary, and the third in the paravertebral. So we came out with some very fascinating findings. So when we injected in the paravertebral space and we did a sagittal section, we found a lot of the drug the injected into the intercostal space in the paravertebral space, a small contribution in the interligamentary space, and none in the erectospinal plane. And when we injected in the costotransverse or the interligamentary space, we found that the costotransverse ligament was highlighted. The injected did diffuse into the paravertebral space, and a very mild diffusion into the intercostal. And again, there was no diffusion into the erectospinal plane. So when we injected latex in soft embalm, we found that the entire latex was contained in the erectospinal plane, and there was hardly a small segment of latex in the paravertebral space. Now, this, if you consider as a local anesthetic, it is not going to give you any analgesic quality. So there are only three sites for injection. One is the erectospinal plane, second is the interligamentary space, and third is the paravertebral space. Now there are a lot of articles which mention many injection points in the paraspinal space. Now, if you look into the cadaveric sections that we did, you find that there are hardly any space to have any injection points. So these are the only three injection points. So this was a video which shows that the needle goes through the transverse ligament into the interligamentary space and the costotransverse ligament into the paravertebral space. That's the ventral nerve root, which is being held by the forceps. So you can position your needle tip at this point. Just few days back, we published this article, and this is regarding the erectospinal plane infiltration and the affection of the ventral rami. This is again a cadaveric study. We found that it really does not stain the ventral rami. Everything what stains is the dorsal rami. You can see that there is a spread from cranial to caudal and medial to lateral spread, 20 ml at a level of T9. This was still low down, and you can see that the ventral rami are none of the ventral rami are stained. So it's usually the dorsal rami which are blocked and not the ventral rami with the erector spinae plane. Now, if you puncture at the level of T9, you'll find the spread in close vicinity from T7 to maybe around this T10. That would be just the spread, and this was the at the level of the puncture that we could find, and none in the ventral rami. So ESP is a dorsal rami block. That is what we would like to conclude with this particular cadaveric studies. Of course, the clinical investigations, we find something very unusual and different. That is basically because with a spontaneous ventilation or with mechanical ventilation, the dye usually it percolates to the some of the unusual sites through uh, the path which has got the least resistance. So that could be a possibility in the living subjects. Coming to the PENG block, now we studied the mechanism of action. Now there's a lot of articles which mention that it affects just the articular branches of the hip, that's the femoral and the obturator nerves. And if you inject just at the site which is lateral to the psoas tendon on the iliopectin eminence, so it is possible that the drug would just be contained there and doesn't spread anywhere else. And it's a true pericapsular block. That what has been mentioned by Tran and colleagues as well. So when we did this study in 8 cadavers and 16 specimens, what we found that when you inject local, at this point, the dye was methylene blue 0.1% and it was 20 ml. This is the psoas tendon, that's the iliacus muscle. This is the femoral nerve, and this is the fascia iliaca. The above would be the fascia lata, and this is just beyond the iliopectinal eminence. The iliopectinal eminence would be this one, and you have the iliopectinal bursa as well here. So you should not invade the bursa, or it becomes a bursal block. And and almost 30% times the bursa communicates with the capsule. So the idea was to understand the spread, which would be below the psoas tendon and beyond that into the femoral nerve and into the lateral femoral cutaneous nerve and away from at lateral femoral cutaneous nerve more laterally at some unusual sites. You can see that this is the site for obturator nerve, which comes to the obturator canal, and the articular branches then would be uh, emerging through this, and then it would be ending in the capsule here. So when we injected the PENG is the green. So this would be the green dye, the PENG, and we injected blue in the CP because we wanted to see whether the CP and the PENG have different planes. And we found exactly the same. The CP was more ventral while the PENG was more dorsal. But of course, we found that the green dye would come more ventrally as well. It means that the green dye was percolating through the fascia, through the iliacus muscle and coming more ventrally as well. When we dissected further, we found that now this is the inguinal ligament. We found that the dye went as far as the lateral cutaneous branch of the iliopagastric nerve, which was stained, the lateral cutaneous branch of the subcostal nerve, which was stained. Now this is the entire green dye which stained almost everything. You can see some strips of green dye coming more ventrally from the dorsal side. The main obturator nerve was not stained. Here you can see the accessory obturator nerve. This is the anterior inferior iliac spine, the iliopubic eminence, and the green dye going down and staining the accessory obturator nerve from below. We also found the lateral femoral cutaneous nerve of thigh, which was stained, as well as the branches of the posterior division of the femoral nerve staining. And we also found the even not has not been shown here, but the anterior branch of the obturator nerve were also stained. So many of these branches were stained, almost all the branches, and it went as far as lateral beyond the iliac crest, beyond the anterosuperior spine. So we came to a conclusion that this is not a true pericapsular block, but it's a global block for hip joint. If you give around 30 ml, in fact, if you increase the volume, a single point injection would give you a global block for the hip joint. This is just a schematic diagram. The point of injection and the flow of the local anesthetic at these sites. And then this is the infrainguinal at the obturator nerve, the divisions of the femoral nerve, and then it goes even along the fascia iliaca towards the femoral nerve. So that would be probably the spread of the injected in a cadaver at least. We are trying to correlate with some contrast studies in the live subjects as well. So it's not a true pericapsular block. This is what we came to conclusion. So cadaveric studies can be uh, a way or a path to understand the mechanism of action of the novel blocks which have been described in literature. So one of the unusual findings of Peng block was that when we did a cross section. Now, why do you do a cross section? Cross section you do is to understand the deeper spreads and unusual spreads without disturbing the flow of the dye. Because when you start dissecting your fingers and with the instruments, there would be percolation of the dye elsewhere. But when you take a single section, you will not disturb the spread of dye. So now this is the iliacus, that's the psoas tendon, that's the iliopectinal eminence, that's the psoas tendon. This is the iliacus. These are the lateral part, the tensor fasciae lata, vastus lateralis, gluteus maximus. You can see the dye going as far as the path of the lateral femoral cutaneous nerve. But what was unusual is the intraosseous spread. You can see the intraosseous spread, and we found it in 4 specimens out of 8. So 50% intraosseous spread. So going deep into the literature, I found that there is a connection between the point of injection of the Peng block and the intraosseous, and that was quite surprising for me when I went through the literature. Coming to the last part is the calcaneum block, which I mention it as an interfacial plane block. Now, routinely, what we do is we give popliteal blocks, and we find that though they are the of choice for all the foot and ankle surgeries, but the calcaneum surgeries, I thought that it must have some separate innervation. Now, when you do a calcaneum surgery, you have the incision on the lateral aspect, and the plate and the reductions are made from the lateral aspect. So the lateral part of the incision is all innervated by the sural nerve, while the entire bone, that is the calcaneum, is innervated by the inferior calcaneum nerve. Now, the inferior calcaneum nerve can arise or emerge from either the lateral plantar nerve or the posterior tibial nerve. There is also another nerve, that is the medial calcaneum nerve, which can be absent in several of these specimens. So ideally, you should be blocking the inferior calcaneum nerve for the calcaneum and the sural nerve for the skin and the subcutaneous tissue. So you have got 2 injection points. One is the sural nerve and second is the inferior calcaneum nerve. Now, anatomically, you can find the inferior calcaneum nerve, but if you look into ultrasound, a slow progression of the ultrasound probe from the medial aspect above the ankle joint and over the medial malleolus. When you come down just beyond the medial malleolus, you'll be able to see the split of the medial lateral plantar nerves as well as the calcaneum nerve, inferior calcaneum nerve. So these two nerves, the sural and the inferior calcaneum nerve, are important. Now this is one of the specimens. This is a amputated specimen. So with the consent of the patient's relatives, the surgeon, we usually perform in some good specimens. We are allowed to do this block, of course, with the permission of the institute as well. Now, when we do a sural nerve block, now this is the paranerval tissue which surrounds the sural nerve, one which is being lifted up. And you can see that the sural nerve on the lateral side, it splits into several branches here. These branches may not be visualized, but what you can see is the sural nerve very nicely, which is visualized. And when you inject methylene blue dye, this is just around 1 ml which was injected. You can see the deep stain of the sural nerve and the bed of the sural nerve. So the sural nerve can be easily visualized just in the subcutaneous tissue on the tendo achelis tendon, and then it goes more laterally here. So this is the sural nerve. So once that is blocked, then you look at the on the medial side of the foot, below the medial malleolus, you will find the medial plantar nerve, you will find the lateral plantar nerve, and you will find the inferior calcaneum nerve. Now, this inferior calcaneum nerve is important because it goes through a tunnel, and there are several of these branches. So, what I thought was probably if you can inject along this plane, horizontally along this plane, just above the calcaneum, just above the calcaneum bone, that is along its medial and superior border, along this plane, you might get hold of the inferior calcaneum nerve. So when we injected along this, we found that the medial plantar, the lateral plantar, and the inferior calcaneum nerve all were blocked. And this I found that this was the high medial calcaneum nerve. So this is arising separately and going right into the bone, while this is arising from the lateral plantar and going into the bone. So if you block along this, we will probably block all these nerves and block the uh, and have an effective blockade of the calcaneum for the calcaneum surgeries. Now we have randomized popliteal versus these blocks, and we find that these blocks have become quite effective. And we do it under general anesthesia, so we find that intraoperative the requirements of fentanyl and immediate postoperative requirements of opiates. Of course, we give them multimodal analgesia as well. So we find that this block is quite interesting. Now, apart from that, I did a cross section at this level. I wanted to see the deeper levels at which this dye would be percolating, because beyond this, you won't be able to dissect. That's the limit. So we did a cross section and we found that cross section below the medial malleolus, we found that it lies very close to the abductor hallucis. Now this is a muscle which when you palpate the medial aspect, you will find a very soft spot. That soft spot, what you find on the medial aspect at the midfoot, is the abductor hallucis, and this is the neurovascular plane in which it lies. So the entire is the neurovascular plane. So it goes quite deep, and it blocks the medial and the lateral plantar nerves as well. I'm not sure whether this block would help for the foot surgeries and the toe surgeries, but definitely the calcaneum surgeries are doing quite well. And we found that just yesterday we had a case where we found that the time to first analgesia was 14 hours, and that was quite pretty long. Uh, Time to rescue analgesia, not the time to first analgesia. The rescue analgesia was 14 hours. So this was a pretty long time that we thought that this block uh, is we appreciate that particular block, in fact. So we come to an end of this particular lecture. We have cadaveric workshops in AOR Hyderabad. August, it's already full. But we have one coming up in Isra, Prague in September. Then we have in Ahmedabad along with Hetal. Hetal is doing a lot good job along with me and is supporting me a lot in the West, particularly for all my cadaveric workshops. He's playing a very big role. AIMS Nagpur, which is being conducted by Bhuvaneshwari and team from Nagpur, Rasika and all. Then MGM Navi Mumbai in October, where we have a couple of again all AORA faculties. So this we are tying up all with AORA. All further cadaveric workshops will be a part of AORA, and probably the Board of Studies AORA is going to make mandatory for all AORA fellows to attend these workshops. So that's all from my side, Divesh. Thank you very much.
Uh, Thank you very much, sir, for an enlightening lecture. Uh, the house is open for questions. Any fellow, any mentor, any faculty feels like to ask
Good
questions.
evening, sir. Can I?
Yeah, Vipin, please go ahead.
Hi, Sandeep, sir. Good evening, sir.
Good evening, Vipin. Very good evening.
Very nice dissection you are doing and very minute branches you are saying. Uh, I just question about electrospinal block, sir. Hello,
Yes, yes.
can you?
Please go ahead.
Yeah, sir. Just a question. Like in which position you are giving this dye? Like patient cadavers are in which position? Lateral, prone, or
So, Vipin, the cadavers are all in prone position. We
okay.
cannot keep them lateral all the time because of logistics. So they would be
Like
prone all the time, and the
lateral
dissection would
prone
be
position.
yes,
Yeah, you are giving drug in the prone position
yes, yes. The drug will be given in prone position.
and keeping the cadavers in prone only till dissection.
Yes, keeping the cadavers prone in dissection and doing cross sections. What happens is these cadavers, the one which I demonstrated, the latex ones, these ones. So these ones
Sir.
will be, this one will be going into the freezer
Okay, sir.
until the latex totally solidifies. So it takes at least 24 to 48 hours. While these ones, these are dissected at around 30th minute. That is the time when usually we have a surgical incision. So these are
Mhm.
dissected at that point of time.
So like roughly around half an hour to 45 minutes after
Half an hour
putting
to
that.
45 minutes. Yes, yes, yes.
Until that time, cadavers are in prone position only.
So they will be in prone position. They won't be moved to supine.
They, they are not moving to spine. They are in prone
No, no.
only till the
Yes,
dissection.
yes, 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 yes.
Okay, sir. Because we are giving blocks now. So till now we are giving around more than 500 blocks. And
Yes,
in
yes.
my all blocks, patient has hypotension and like in 100% patients, I got hypotension, even if I
Yeah,
gave at the lumbar level also.
yeah, that's what I'm saying, Vipin. See this particular slide. You will see
Uh,
that uh, if you give at this point, you can see that, sorry.
no, this is T5. Even at the level of L3, L4 also,
Yes, at the level of,
100%
yes,
patients are having hypotension and the heart rate is like 60, 50, roughly, like it won't move at all throughout the
yes,
surgery. 2, 3 hours it
correct.
will be severe hypotension. Like hypotension means BP will drastically down to 84, 85 throughout the surgery.
Yes. So, no, I agree to some extent regarding the thoracic the thoracic. Yes, I agree because this is what we find usually, and this is also what we find the dye going from ESP to the epidural space. This is
Mhm.
also what we find in the living subjects where you find ESP going to the epidural space. That's why I always try to caution
Uh-huh.
those who perform bilateral ESP, when you do a unilateral ESP, always look for the hemodynamics and then go for the next ESP on the other side, because the hypotension is it occurs quite rapidly. That is what I have seen, because the injections are done quite rapidly. The speed of the injection, that has to be controlled. That is not being controlled in all these facial plane blocks. This is what the problem is. Now, regarding the lumbar ESP, the cadaveric study mentions 0 to 16% of the dye going from the ESP plane to the
Mhm.
epidural space or the lumbar plexus. But when you
Mhm.
do a ESP and you scan in live subjects, we have seen the dye going from the ESP plane to the lumbar plexus. Yes, we have seen that. But
Like
I'm not sure whether, and it's all related to the volumes. We have seen that it's all related to the volumes.
so in all lumbar surgeries, lumbar fusion surgeries, 1 level or 2 level, we are giving 20 each side. And in
Yes,
all patients, till now, we have more than 500 blocks has been performed. And in all
yes,
patients, we have seen hypotension is there.
yeah,
So
that's
maybe
the
the drug
possibility.
is, yeah, that maybe the movement is like because patient is in prone and with the breathing movement and the
Yeah,
facial plane keep on moving. So drug is
yes,
seeping up and through the paravertebral space into the lumbar area.
yes,
So
Sir,
just
carrying forward this discussion, in the initial formalin-based, you showed the spread towards the paravertebral space on the left side. But your recent article in 2024 in RAPM doesn't show any spread. So is the
no,
type of preparation makes a difference? And what about the clinical? Right now from the discussion, everybody would conclude that there is a clinical meaningful analgesia if we give thoracic ESP for breast surgery. So how
Yes.
do you explain the discrepancy between cadaveric studies and the clinical?
So there are a lot of factors which would affect the which would, and you cannot extrapolate the cadaveric to the clinical studies. Basically, the type of cadaver, the type of injected, then the resistances that are offered by the facial planes, the age of the cadaver, and then the consistency of the tissues. So many things matters. The spontaneous ventilation, the vascular pulsations, all these things they matter in when you have these findings. So when you do a cadaveric study, not everything can be extrapolated to the clinical study. I agree with this. We have ESP for the breast surgery. We have ESP for the cardiac surgery. We have ESP for the abdominal surgeries. Probably, if you analyze one of the articles which I am trying to analyze right now, there is some anatomical explanation to this where there is there is a connection between the nerve fascicles which arise from the ventral root and the dorsal rami, and then it goes along the intercostal plane, and the ESP plane connects with the SAP plane and then the anterior plane. And there's a beautiful anatomical article which I'm trying to analyze right now. I have not yet concluded with that. But once that is done, probably that could be one of the another explanations to this. Now, the other explanation is the animal experiments which they have come out with. And when you inject this dye in the ESP plane, they have found this dye in pigs in the lymph nodes, in the along the sympathetic chain, along the intercostal nerves as well. And it is said that the local anesthetics which has been taken up by these lymphatics, they're trying to squeeze this local into the vicinity of the nerves, because the lymphatics they follow the nerves. So that is another proposed mechanism, but that's again in the as an animal experiment. It's not correlated to human totally.
Sir, carrying forward this discussion, you have labeled in one of the slides ESP is the dorsal rami block. But clinically, you yourself said that is working for breast surgeries, it's working for enterolateral thoracotomies,
Hmm.
cardiac surgeries, and abdominal
Yes.
surgeries. So, how do you
Yes.
explain your statement vis-a-vis the clinical studies which we are having in form of RCTs as well as meta-analysis?
Yeah, correct.
Similarly, sir, similarly in lumbar spine surgeries also, if hypotension is happening in even lumbar ESP, that means sympathetic block is happening. So that means drug is reaching into spine also.
So, Divesh,
If sympathetic block also.
this particular lecture was all based on cadaver, so it's all related to anatomic block efficacy and not a clinical block efficacy. Now, if you look at all these slides, all these slides which have been published, they all mention that it's dorsal rami. So coming to this particular thing, I feel that this ESP is still a dorsal rami block, but the ventral, whatever ventral is ventral spread, what you see is hardly you will find in few cadavers, not in all the cadavers. Now, these number of cadavers also, it all depends on the number of cadavers. We don't have sufficient number of cadavers. For example, this was done in hardly 4 or 5 cadavers. So that's the problem. While this was done in how many? This was done in almost 8 cadavers. This was done in 8 cadavers. So we had 16 specimens here. And while this was done in only 2 cadavers. So we did not have much. So it's hardly 4 specimens. So we cannot quote exactly the incidence of the injected going ventrally. Now Vipin always keeps on saying 500 blocks and all 500 had hypotension. I think he has to come to a conclusion with a solid evidence of data. Then only it's possible to understand why and how and when would this block act.
Uh, Dr. Vandana wants to ask a question, followed by Dr. Rupinder. Vandana, madam, please.
Yeah. So this is a little way away from the topic. I was wondering that you described that the phrenic nerve goes to the medial side, and we have discussed in context of the interscalene block. Now, if we are to give the intermediate cervical plexus block, if we give it further down, will it affect the phrenic nerve less? I was wondering, now that it moves away.
No, I could not get you. In the intermediate cervical plexus,
Plexus block, instead of
uh-huh.
giving it at the classical point up there at
Hmm.
the middle of the midpoint of the sternocleidomastoid, if we come down and give the block, will its effect on phrenic nerve palsy be less? Because it's the phrenic nerve has moved more medial by then.
No, I'm not sure about this, Dr. Vandana, because the phrenic nerve itself has got several courses. Like, for example, the C4, the C5. The C4 has got a major contribution, of course. The C5, a lesser contribution. Now, when the phrenic nerve it forms, you can get a couple of these roots coming out. Like, for example, if you look at this, it may not be a complete it may not be a complete phrenic nerve block. Now, this one, when we described this is yet to be published. But if you look at this, there are these two. So these are forming the phrenic nerve. These
Right.
these are forming the phrenic nerve. Now,
Right.
it all depends upon whether this particular is stained completely and this is not stained, or both would be partially stained.
Right.
So these, like, for example, this is coming from C4, this is coming from C5, forming a phrenic nerve here. Sometimes it is formed very, very distally. So only a part of the phrenic nerve, that's this root or this root, might get stained completely and not the complete phrenic nerve. So you cannot really predict at what level you would inject and how much percent you would get the block.
Okay. Okay.
Dr. Rupinder,
Thank you.
Yeah. Good evening, Dr. Sandeep. As usual, excellent presentation. What I want to ask you is, in your clinical practice, when you have to give analgesia for shoulder surgery. So, as you said, that infraclavicular, if you target the posterior cord, do you use it routinely? I mean, how do you go about giving analgesia for shoulder surgery?
So for shoulder surgeries, what we do is we give, now this is the suprascapular. So we give an isolated suprascapular nerve when it departs from the the posterior division of the superior trunk, and we give it more posterior and lateral, and we give around 4 ml here. And 7 ml of local anesthetic is given at the level of posterior cord between the lateral cord and the posterior cord. So that in between these two. So we really do not want a donut sign like a proper infraclavicular block, but we would like to have just the local anesthetic that would soak the lateral cord and the posterior cord. And we give us around 4 to 5 ml of local anesthetic for the suprascapular nerve. And then the patient goes on multimodal with diclofenac and paracetamol. And post-operatively, before sending the patient home, which is usually in the evening or the next day morning, they have a buprogesic patch.
Okay. So, so how much volume do you give for the posterior cord you're giving? You said
7
7
ml.
ml? 7
Yes.
ml you're giving. Okay.
Yeah, 7 and 4 ml.
Okay, 7 and 4 ml. Okay, fine. That is what I wanted to know. And the second question was, you talked about the sural nerve and the inferior calcanean nerve. Do you have some ultrasound pictures for that?
The ultrasound, I could not get those pictures today.
I mean, it is just for my, of course, you
Yeah,
showed the beautiful
what I will do is, yes, I will send it to you across.
Okay, thank you so much.
Yeah,
Bye.
yeah.
Thank you.
any other questions from anyone? Any comments? Any suggestions?
Devesh, am I audible? This is Ram Kumar
Yeah,
here.
you are audible, Dr. Ram. Please go ahead.
Good evening, everybody. I mean, again, it was a wonderful presentation by Dr. Sandeep Diwan. I just have a question. Like, we have been doing, I think whatever Vipin was telling was about bilateral lumbar puncture, lumbar ESP, which has caused hypotension. That's what I could understand. But thoracic ones, I think we have been placing a epidural, ESP catheter for all our transplants, the renal transplants and uh, other chest procedures and all. So we actually give a bolus of about 0.25% bupivacaine, about 10 to 12 ml, and up to 15 ml, and run an infusion. And we have not come across hypotension, and we do most of the times in a semi-prone position and turn them supine for the procedure. This is one. Our observation, and definitely not hypertension, and our opioid requirements are much, 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 much lower when compared to without the block. Yeah, this is one thing, and I think I want to ask sir about the recent 3D analysis of the paravertebral space. There's been
Yeah.
8 studies which have been published. I think for the sake of the fellows, I usually stress our fellow to go through that, and that's a wonderful description about why it spreads. What is your thought in your all these studies, because you've been doing it for quite long time now?
Dr. Ram, I think this was in Korean Journal of Anesthesia with the microanatomical and CT studies. Yes, it's a beautiful article, and I think it should be read by each one of us. There are a couple of mechanism of actions that have been mentioned even by Ki Jin Shin in one of his articles. That's a narrative review. So I
Yeah,
think
that was the one which
yeah,
I was referring. Yeah.
yes. So if you can go through those articles, we will we will be more confirming about the mechanism of actions. To me, basically, when you do a cadaveric study, I always mention that it's not to be extrapolated directly to any clinical. Do not jump to conclusions, because all these cadavers, as I mentioned earlier, we have several types of cadaver, several type of injections. We have several performers. It might vary from one to the other as well. In the cadavers itself, from the left to right, that also can vary. Then in prone position, if you inject the injected and you dissect in the prone position, you make the cadaver supine, you find some different finding. In the cross sections, the deeper injections, the deeper spread would be easily evaluated or investigated. So there are a lot of things to be taken into consideration. So you cannot jump to conclusions immediately.
Hello.
Yeah.
Hello.
Thank you, Doc.
Ritesh, go
So,
ahead.
Sandeep sir, as usual, it is
Thank you, Ritesh.
always an eye opener hearing your presentation. Sir, carrying forward that rectus spinae plane block, I was just 2 days back had an interaction with Dr. Kijit Chin, and I think we were discussing the same thing. Right now, they are advocating that for the ventral aspect, they are not
Yes.
what you call between the costotransverse, that ITP space, that between the intertransverse ligament and between the costotransverse ligament, to place the
Right.
needle there. So Dr. Kessler questioned him that it's not a ESP block anymore, it's a ITP block. So he was slightly mum on that. So I think and regarding what seeing your presentation and discussions, I think it is not it is the spread in the intercostal space that is most probably giving the slight ventral analgesia. I never use the rectus spinae block for my any ventral surgeries, so that might be the case. And regarding the second part, regarding the phrenic nerve, which you were telling, basically we have not done much. We have done around few cases, giving around 5 ml of drug in the upper trunk level and 4 ml in at the level of spa to see the diaphragmatic paralysis, and we do a pre-op diaphragmatic exertion and post block again we do it. So obviously, we even at the level of SPY, we are injecting around 5 ml. We are seeing slight decrease in the phrenic nerve function, the diaphragmatic exertion.
Right, Ritesh. Thank you very much, Ritesh,
Thank
for
you,
that.
sir, for your amazing presentation. Thank you, sir. Thank you.
Any other
Devesh,
questions? Yes, sir.
Devesh, this is one about the lumbar ESP. Can you see this slide?
Yeah, it's visible to us, sir. Please go ahead.
Yes. So see, this is the this is what Vipin was saying in the erectospinal plane. Then this goes into the paravertebral space, and then into the lumbar plexus. This is the spinal cord. This is the lumbar root. Now this is a different plane. This is the axial plane, but this is a oblique axial plane. We can see the nerve root appearing on one side and the contrast which delineates the or highlights the nerve root on this side. These are the intervertebral foramen where you won't find any dye inside. And again, this is all the dye which you can see is behind the transverse process. This is a 3D view, of course. So now this is something different type of axial section where it is 3 or 4 vertebrae. Now, what I did was 3 or 4 vertebrae which can be seen together. Now, this is the psoas major, quadratus lumborum, erector spinae. You will see it slight vertical because this is a totally different angle. Now, this is the catheter in the erector spinae plane. So, what I did was I was trying to find out what is the volume that would reach the lumbar plexus. If you give 10 ml, it would be still here, in the erector spinae plane. If you give 20 ml, it would be somewhere just beyond the transverse process in the lumbar paravertebral area. So this is the transverse process, that is the lumbar paravertebral area, and this would be the lumbar plexus area. And if we give around 40 ml, it is then that it starts going into the lumbar plexus area, and you can see the difference between this highlight of the lumbar plexus, which is whitish, against this backdrop, where it's totally black. So it is all volume dependent. The more volume of local you try to inject, and that through a catheter system, you will find it going into the lumbar plexus. And in fact, we have published this, that with the catheter system in the ESP, you will find loss of tendon reflexes at the level of the knee and as well as the level of the ankle. That's all, Devesh.
Any other questions from anyone?
Sir, so it means we can conclude that ESP depends on volume of the drug, patient position in which you give the block and which you keep the patient. If you keep the patient immediately supine after giving, maybe the drug won't reach. But if you keep the patient prone, then chance of drug reaching the space is more. And the volume, if you give.
Yes, sir, that is quite possible, Vipin, even in
I think
patient.
Dr. Ram didn't. I think that's why Dr. Ram didn't see the hypotension and all, because they are giving in the lateral position and then making the patient supine. So drug is not reaching. If they keep the patient in prone, maybe the drug will reach that.
That is quite a possibility, Vipin. The position can also cause this particular thing.
Because
Yes.
the position, the gravity will help in the seeping the drug through the space.
Yes.
Vipin, I just want to add one thing here. See, it's also, I think what I meant is like we have given ESPs in lateral, semi-prone, and prone also. But you know,
fine now after immediately giving the
correct.
blocks.
We'll turn off this thing. But I think, yeah, but I think sir will also agree with you know, the way it's a multi faceted muscle, this erector spinae, and you know it will have insertions and origins at multiple levels, and also probably it's whatever we have are cadaveric studies. That's what the explanation is given, and I think it's very much informative that the drug spread in a live scenario is totally different. That's what
Yes.
I think
Yeah.
way to conclude. Yeah.
Yes.
And this bilateral ESPs at the lumbar level, probably you may be doing it for spines, if I'm correct, right?
Supine
Do
and
you do?
90% spine.
Yeah. Do you do it pre-op or the post-op?
Pre-op, before surgery.
It should be pre-op.
Yeah. It should be always pre-op, right? So that
Yes.
I don't have an experience with that, but I can say almost none of our because, and also the concentration of the drug So what
Yeah.
we use, because we always in all the blocks
0.25%, I mean, 20 ml on
0.25.
20 ml on
Yeah,
like,
correct.
and we do
So
before incision, like after induction GA and making the patient prone, and then we'll give bilateral ESP. And by the
So-
time incision will happen, 30 minutes will be over painting, draping and all.
yeah,
So,
next question comes, what is the incidence of hypotension in a spine surgery with or without ESP? You know,
yeah,
because
without the ESP, it is not that much. That's I'm telling. We're keeping
Yeah.
all things the same, and amount of opioids, amount of inhalational. And
Yeah.
with that, in ESP given patients, we have seen that hypotension is more and it is more sustainable throughout the surgery. Like surgeons are
right.
happy,
fine,
patient is having
So
getting hypotension.
yeah,
Surgical side
what
is
we
very
what we
well.
normally do is will not increase more than 0.25% as a bolus if you are giving for the breast analgesia. We most of the times use it for analgesia, and our infusions will only go at 0.1% bupropion once we give a bolus. So that's what we do. Maybe I think it requires some more. I think that basic the drug dynamics I think may change. That's what I think. I mean, as it's always explained with the cadaver and live patients.
Yes.
Thank you.
Any other questions before we wind up? So, thank you, Dr. Sandeep sir, for this enlightening lecture on the cadaveric anatomy and the contrast. And I hope every one of us has taken back some take-home message. Thank you, sir, for sparing your valuable time and sharing your wisdom and knowledge with us. With this, I would
Divesh, not some, loads and loads of knowledge.
loads and loads. Okay, I correct my statement. Loads and loads of knowledge.
Ritesh,
Thank
as
you.
usual.
Sir. No, sir, not at all.
Okay.
Thank you.
Thank you very much. Good night, everyone.
Good night.
Thank
Thank
you
you so much,
all.
everybody. Good
Good
night.
night. Good
Thanks a
night.
lot. Yeah.